Mona. Thank you for the invitation, and Amy for that lovely introduction. I'm so very excited to be talking to a group of women. I really believe that it's going to take women to change the world today. And boy, do we have a lot of work to do. I'm gonna be talking today about syphilis, which I sort of fell into um, right at the start of my career when I first started in infectious diseases, which was not long after Mona, I think. I hadn't actually seen a single case of syphilis, and now I think I have probably been part of reviewing several thousand cases, and that is not a good thing to say. And the thing that has sort of motivated me to continue, I'll be honest with you, is pregnant women and babies being born with congenital syphilis. As you know, that should not be happening in Canada today. And the fact that it is, and to the extent to which it is happening, is completely unacceptable. If this were happening, I believe, to the voting public, I think we'd see a lot more action. So, for those of us working who have the privilege of serving women who are being affected by this, we still have a lot of work to do. So, let me just find my presentation here. Okay, so screen share. All right, can everybody see that? Yes? I'm going to put it on. Amy, that's good?
Yes. All
All
good.
right, perfect. All right. So, what I'm hoping to cover today is, as Amy requested, to provide an overview of syphilis, common signs and symptoms, key stats, current state, how it affects pregnant women living with HIV, and chances of co-infection if the mother has syphilis. So, just before I am going to go back a second here, I have included fairly graphic clinical images, so I hope that that's okay. But I think that that's really important if people are comfortable with that to show what this looks like. So, what is syphilis? So, syphilis, of course, is an infection. It's a sexually transmitted infection that has been around forever. And some famous syphilitics we think were probably James Joyce, Idi Amin, Al Capone, Lenin, Christopher Columbus, as well as Beethoven. So really, it has been around forever, and we know how to prevent and to treat this infection. So the fact that we're having such a problem today, is really unacceptable. So the first recorded outbreak of syphilis in Europe is believed to have been around 1495 or so, so several centuries ago. And then in 1905, Schotten and Hoffman discovered the bacteria Treponema pallidum that causes syphilis. And just a year later, the first diagnostic test for syphilis was developed in 1906. It was called the Wassermann test. And just a little bit of other history. Alberta Sexually Transmitted Infection Services has been around since the 1930s, and I had the opportunity to review some uh, old records that dated back to that time, and there were still people having the Wassermann reaction test done. And so it was pretty interesting to see that happen. In 1943, shortly after the discovery of penicillin, a group of investigators in the United States successfully treated four patients with syphilis with penicillin. And so it was one of the very first infections that penicillin was used to treat. In fact, one of the first infections that antibiotics were used to treat and cure. And so fast forward now to 2020, and global syphilis rates are rising rapidly, particularly in high-income countries. And in Alberta in 2019, we had the highest rates seen since 1948. So really not good. So syphilis is this very pretty bacteria, really, and I'll show you a fluffy toy that I have as well when we're finished the presentation. But it's caused by this spirochete, which is the spiral bacteria called Treponema pallidum. Um, how is it spread? So it is spread through intimate or sexual contacts, and so by intimate I mean that you really have to have close flesh to flesh contact. It's really, we don't think that just sort of casual kissing can pass it on, but we do think that, for example, um, there have been some case reports of mothers who were infected with syphilis. They can chew, they sort of pre-masticate or chew up the food to give to their baby. We think it can be passed on that way. And then, of course, through any sort of penetrative sexual contact, oral, vaginal, or anal. And then from pregnant woman to child, and usually the transmission occurs during the pregnancy itself. So this is different to HIV, where most of the transmission occurs at the time of delivery. Um, in the case of syphilis, it can be passed on from mother to child, we think, as early as 9 weeks of pregnancy to the unborn fetus. So who is being affected by syphilis in Canada? So these are some statistics put out by the Public Health Agency of Canada. And so of course, as you know, national data tend to be to lag behind. But if you look at what is happening, first of all, among females, the cases among females tripled between 2018 and 2023, so that in 2023, although 64% of cases were male, the increase among females was much faster than it was among males. And we also now see, of course, if we're seeing cases rise among females, that is typically through heterosexual transmission. And so, again, bisexual behavior um, among heterosexual persons, there was a 177% increase. And although males aged 30 to 39 had the highest rates of syphilis, females were younger, 20 to 24 and 25 to 29. Um, if we look at it as well as what is happening nationally, you'll see here that rates of syphilis appeared to rise until about 2022 or so. And then 2023 and 2024 are showing some promising declines. But you can see, of course, that, this is where we would like them to be, is down here somewhere, that we're still many times higher than where we would like to be. So although rates are starting to come down, we still have a lot of work to do to maintain that decline in rates. There's also quite a bit of difference depending on which part of the country you're in. So this map of Canada here, the darker the color purple, the higher the rates of syphilis. And the rates are calculated per 100,000 population. So obviously in the territories where they have very few people, these rates are extremely high, 311, 269 per 100,000, but they have a very tiny population. And so, even small numbers can put those rates up quite significantly. But I want you to take a look at what is happening in Saskatchewan and Manitoba. And this is showing you 2023 numbers. In 2024, I can tell you that this was up even more. So Alberta has also seen an increase. But the highest rates, some of the highest rates now are in the prairie provinces and the territories. Um, Anytime we start to see cases of syphilis increase among women of childbearing age, we can expect to see congenital syphilis. So congenital syphilis is syphilis in a child who's born to a mother with syphilis. And again, in Canada today, that expected number of cases should be zero. We should not be seeing any babies being born with syphilis in Canada today. The reason is that if you access prenatal care, um, part of the screen, automatic screen for as part of the infectious diseases screen is for syphilis, no matter where you are in the country. And that's been going on now for some decades. So, of course, what this means is that there are women who are not accessing prenatal care, and we'll talk more about that in a few minutes. So, in terms of what is happening with congenital syphilis cases, so we, would like to see that number at pretty close to zero. And the numbers of congenital syphilis cases were rising, and it looks like they might be coming down now in 2023. It's hard to know if that is a real decline or not, and we'll have to see what the national numbers for 2024 show. Um, again, this does tend to vary depending on which part of the country you're in. But Saskatchewan and Manitoba have seen the greatest increases. Although I was interested to see from the national perspective that it looks like the cases are up in Ontario as well. And I understand that much of this is happening in Northern Ontario, where among women living in First Nations communities. So I mentioned to you that there were, has been the expected number of syphilis cases should be zero. And in 2023, there were 174 reported cases of congenital syphilis. Um, if we take a look now at the proportion of cases that are female, so meaning that this is predominantly a heterosexual outbreak, again, we see a difference depending on where you are in the country. And so in the territories and the prairie provinces, what we're seeing is predominantly heterosexual persons being affected by syphilis, whereas in the rest of the country, it is predominantly gay and bisexual men who have sex with men. Although even Vancouver, Toronto, Montreal now are starting to see a rise in cases among females and starting to see a few congenital syphilis cases. I was in Vancouver for a meeting um, just a couple of days ago and met somebody from their Oak Tree Clinic, and they said that they have seen six babies with congenital syphilis so far this year. So it looks like they might be starting to see an increase as well. And for them, it has been women living in their downtown east side and persons who are using substances and particularly injection drug use. So why is this happening? I think I think there's a bit of a difference depending on which population you're looking at. So the rises that are being seen among gay and bisexual men of sex with men has been attributed to a number of different factors. The first is thought to be the messaging around U equals U. So I think you all are familiar with U equals U, which is where HIV and persons living with HIV with an undetectable viral load cannot transmit HIV to others. And so that has led to reduced condom use, increased number of partners, and it has meant that STIs have come back, including syphilis, HIV pre-exposure prophylaxis, and the uptake of that, particularly among GBMSM, has also contributed to that, as well as the availability of mobile dating apps, which makes it much easier to arrange sexual partners. So what about the rise in heterosexual persons? I think that what we're seeing with congenital syphilis is really just the tip of the iceberg of a whole host of other social problems that we're seeing in Canada today, particularly unstable housing, mental health issues, in part geography, rural and remote residents and being in the prairie provinces has contributed to this as well. Um, Historical trauma, as well as ongoing stigma and discrimination in healthcare. um, access to and use of prenatal care. So this one has been a really fascinating question in my personal mind. When I first moved to Canada in 1991, I was so excited to be in a country that had universal access to healthcare. But it has turned out that even though that there's theoretical access to healthcare, there are reasons, of course, that people are not accessing prenatal care. And so some of the work that I've done with some of my nursing colleagues in Alberta, what we've learned is that women are not wanting to access prenatal care again because of ongoing stigma and discrimination. I'm currently working on with some grants in parts of rural Alberta and working with First Nations communities, and we still hear that people won't go to certain hospitals or certain facilities because they feel discriminated again. And I think to myself, how is this still happening today, and what will it take to change that? And I have no answers for you except that we continue to need to think about that and to figure out how to change that. Of course, all of this contributes to lower income and poverty, and as well as substance use, which is often used to support basic needs such as food and shelter. I've also been really fascinated to take a look at the intersection between drug use and syphilis. In Alberta, a few years ago, we started to see a significant rise in the use of stimulant drugs, particularly methamphetamine and cocaine. And we know that stimulant drugs, especially methamphetamine, is associated with multiple or concurrent sexual partners, inconsistent condom use, and the exchange of sex for drugs or money. And in Alberta, in other parts, mostly studies done in the United States, a significant proportion of syphilis cases are reported to occur in heterosexual persons due to illicit drug use, particularly, again, stimulant drugs. Methamphetamines, why is it that this association is seen? It kind of makes sense. We know that they decrease inhibition, so it also increases sexual arousal. It impairs judgment, and similar to what is being seen in Alberta, we see stimulant use going together with opioid use. So it's polysubstance use, and so although opioids per se don't increase the risk for syphilis, it's the addiction and that polysubstance use that often drives people to engage in behaviors that puts them at risk for syphilis. So this brings us back to why do we care about syphilis? So for the person who's infected, you can get sores on the genitals, but 30% do not, or at least we don't think they do. They don't report any symptoms. And uh, because the sores can be painless, if they're on the inside of the genital tract, so for example, inside the rectum or inside the vagina, or even inside the mouth, if they're painless, they may not notice that they're there, or they might be quite small. And if they're not treated, they can go on to get rash, swollen lymph glands. They can also develop severe neurological complications such as strokes or loss of vision. And later on in life, if syphilis is left untreated, you can develop memory changes and or trouble walking. So syphilis, as some of you may know, can go through a number of different stages. So about 3 to 90 days after you've been infected, you go on to develop the primary stage of infection, which again is where you see those sores. And I'll show you some pictures in a minute. If that is not treated, that sore can get better, and they can go into the secondary stage where they can have rash or swollen lymph glands, lose their hair, and again, I'll show you some pictures in a minute. And then, if that is not treated, they go into what is called a latent stage, which is where if we do blood tests on them, they'll have positive blood tests for syphilis, but they have no symptoms at all. And again, if that remains untreated, they go into what's called tertiary or late syphilis. And I'll show you what some of those manifestations are. So here are some of the pictures to show you. So again, 30% of people will have no sores or lesions at all. The sores basically are on the point of contact. So this is one of our um, women who was working sex trade a few years ago. So she was using condoms for vaginal and anal sex, but was not using them for oral sex. And you'll see that she has a couple of lesions here on the lower lips. And those were painless. And so when we first saw this happening, this was in the mid 2000s when we first had a little outbreak of syphilis in Alberta. This led us to promote the use of condoms for oral sex, and to try to provide messaging around that. This here is an ulcer, obviously, on the penis. And again, this is a completely painless lesion. This is a pregnant lady that delivered a baby with congenital syphilis. Again, this is going back to the mid 2000s. And she um, had this for about a month prior to delivery and was seen by the obstetrician, and they decided that that was just a rash that she had from the women's shelter. But when we did test for syphilis, they came back positive. And here you'll see is actually a heterosexual male with an ulcer on the tongue. So the lesions, again, they're classically like this. They're single, they're painless. But they can be multiple, they can be painful, and sometimes the pain is there because you get co-infection with herpes. So if that primary stage is not treated, about 6 months later, it can go into the secondary stage where they have rash, swollen lymph glands. They can also develop these warts here, which are called condyloma lata. So these are the warts of secondary syphilis. The hair can completely fall out. So this man here, it was living with HIV, had a CD4 count of about 50 or so, and was very interesting because he had a rash, a really bad rash on the body, and he had a syphilis test done on more than one occasion, and it came back negative. And we thought, gosh, this really looks like syphilis. And his hair started to fall out. He had a full head of hair. And what was happening is because his CD4 count was so low, the lab, he was not making enough antibodies because the syphilis tests are antibodies, which are, as you know, are proteins that the body makes in response to the infection. So the test came back falsely negative, and what we had to do in the end was to do a PCR test, which detects the genetic material of the bacteria in order to diagnose him with syphilis. And I was really fascinated to see what happened here because within days of treating him with penicillin, he started to develop new hair growth, and his full head of hair was back within a month of treatment. Secondary syphilis can be really bad because you can also develop involvement of the nervous system, including the eyes and the ears. And we've had people develop ocular syphilis, as it's called, so involvement of the eyes, so inflammation in the back of the eye. And if it is left untreated for weeks or months, you can develop permanent loss of vision. And we've had people unfortunately, where the diagnosis was so delayed that they are now registered legally blind. You can also develop hearing loss or ringing in the ears. So these are some really more severe manifestations of syphilis. The rash itself, the rash is very common, but it can look like a whole bunch of different things. It can look like other types of common viral infections. This is a pregnant lady that I was asked to go see a few years ago, and I was told she didn't have a rash, and it's very difficult to see, but she does have these tiny little lesions here on her skin, so she did have a rash. And then it's very common in syphilis to see spots on the palms and the soles. So here's one here, and on the palms as well. She had several. But again, the rash can look like a whole bunch of different things. So the only way to know again if someone has syphilis is to think about the possibility and to treat for it. Um, if that secondary stage is not treated, it can go on to the tertiary stage, and up to 40% of people can go on to develop tertiary syphilis. We were able to do a 44-year review of cases in Alberta, and we had about 254 tertiary cases, and most of them were neurologic involvement with syphilis. So again, that can cause dementia, or it can cause problems with the with walking classically. So if it involves the spinal cord, and we interestingly had three cases of cardiovascular syphilis here, and this is just an example of what might have been happening. This is a very severe case from India. Um, and what is happening here is there's a big blood vessel that comes off the heart called the aorta. And this is an aneurysm, so it's a widening of the aorta that has gotten so big that it has caused this massive swelling of the chest. So it's eroded through the chest wall, through the bone here. And if you could see video here, you would actually see it pulsing. So this man went on to have cardiovascular surgery to repair this aneurysm. And I found out from the physician who was kind enough to share this picture with me that he did very well. You can also get these very nasty ulcers of the skin, the bone, other vital organs. So those are called gummas. And for some reason, that is very rare to see in Canada today. I don't know why, but I've only ever seen one case ever. So, what about syphilis in pregnancy? So, I mentioned to you that the infected mother can pass syphilis on to the baby during the pregnancy, and that can happen as early as 9 weeks of gestation. If that pregnant mother is not diagnosed during the pregnancy, and the baby continues to be infected during the course of the pregnancy. The most severe outcome is that unfortunately the baby can die. Up to 20% of infants can die. Now, in Alberta, since the outbreak started in 2019, we've had 64 infants die of congenital syphilis. I want to put that into perspective for a second here. Measles, of course, is out of control in Canada, especially in Alberta right now. And we've had exactly no one die from measles so far, which is a good thing. But I'm just putting this into perspective because measles is all over the news. People are talking about it. But we had 64 babies die in Alberta alone from congenital syphilis, and virtually no one knows that we even have a problem. If the baby does not die, they can be born with many problems of the organs, such as enlarged liver, spleen, rash, etc. And this is just an example of a baby again that I saw in the mid 2000s. So the baby's liver should be up here and the baby's spleen should be up here, but the baby's liver and spleen are so enlarged that you can see the abdomen is very swollen, and this is where the liver is enlarged too, as well as the spleen. You can see that the baby has a very nasty rash. This is a baby whose diagnosis was missed, unfortunately, at 3 months of age because they weren't tested for syphilis. And they were diagnosed with a very rare type of leukemia called juvenile myelomonocytic leukemia. And so they went untreated until the diagnosis was made at 8 months of age. And the baby was then treated with 10 days of intravenous penicillin in hospital. And the liver and spleen went back to normal, the rash went away, and the baby has done well, thankfully. So how do we diagnose syphilis? So usually it is with a blood test. But when we do a blood test, The lab will typically do the very first time the test is done, they'll do an additional 2 to 3 tests to confirm that somebody has syphilis. And then if you have syphilis again, they will typically only do one test, but that exact algorithm of tests that is done for syphilis really does vary again across the country. But of course, if you do a blood test, it usually takes about 7 to 10 days for the results to come back. And it means that, once the blood is collected, that if you don't have the result right away, that it can, you really need that person to come back 7 to 10 days later. Since syphilis and other sexually transmitted infections, as well as bloodborne infections, go together, we usually do tests for HIV, gonorrhea, and chlamydia at the same time. And if you have any type of infection that causes genital ulcers, such as syphilis, if you're exposed to HIV at the same time, you are at least 2 times more likely to acquire HIV than if you did not have syphilis. Similarly, if you have if you're living with HIV and your infection is not treated and you don't have an undetectable viral load, if you develop syphilis, you're much more likely to pass on both syphilis and HIV if you haven't been treated for either. Um, how do we treat syphilis? So interestingly, syphilis treatment has not changed for decades. So I told you in 1943, penicillin was used to treat syphilis. The treatment is unchanged today. It is pretty well the same in most parts of the world, with a single injection of penicillin, although some parts of the world use daily injections of penicillin. In North America today, the standard is to do an injection of penicillin. So it has to be given into the buttocks in the location shown in the diagram there. So because that is a deep intramuscular injection, it does need to be given by trained healthcare providers. And typically one dose or one treatment is 2 injections, so one into each buttock. Most people can be cured with a single injection of penicillin, but in some situations we need to give 2 or 3 injections, which are usually given a week apart. For example, pregnant women in Alberta today, our guidelines recommend that pregnant women receive 2 injections of penicillin. And so that the first dose would be given on day 0, and then the second injections would be given a week later. If they have neurological involvement, so if they have involvement of the eye, the ears, or the nervous system in any way, then they do need to have intravenous antibiotics. And the preferred treatment is still intravenous penicillin, although alternate antibiotics such as ceftriaxone are being more widely used today. So, I mentioned to you before that I've done work with my nursing colleagues to figure out why is it that pregnant women are not seeking health care and getting tested for syphilis during pregnancy. Again, we heard overwhelmingly that there was still ongoing stigma and mistrust of the health system due to racism and discrimination. But some of the times it's simple things like lack of transportation. Um, so Fascinatingly, I'm working with a First Nations community in central Alberta right now, and it seems so simple a solution to come up with. So they have pregnant women who are taken from the community to a neighboring town where there are prenatal clinics to have their obstetric care. But those clinics do not have the ability to draw blood on site. So they see the obstetrician and they can't have the blood drawn. And their transportation has only been booked to take them from the community to the doctor's office and not to the lab. So if they want to go to the lab, they have to go home, book another transport to go out to the lab. Of course, none of this makes any sense at all. So we're trying to work now with the community to figure out, is there a way for them to have somebody on site to draw the blood, particularly for pregnant women? And if that is not an option, can they take them? Can we book transport simultaneously to take them to the health clinic and to the lab in the same visit? Or even better, part of the project that I've been working on right now is the use of point of care tests for syphilis and HIV. And so we're trying to see if we can train nurses. So for the Health Canada approved tests for syphilis and HIV that we have right now, only healthcare providers can do the test. Although, as part of the grants that we're working on, we hope to have that put in the hands of non-healthcare providers within the next year or so. And then, of course, we've also talked a little bit about the need for more basic support, such as housing, food, for substance use, mental health. So we had 44 cases of congenital syphilis in Alberta last year. And one of my nursing colleagues and I reviewed all of those cases to try to figure out what were missed opportunities for providing them with care. And we have a virtual opioid dependency program here in Alberta, where anyone can be put on to opioid substitution agents by phone. But interestingly, what we discovered is that some of those women were pregnant at the time and did not disclose this, nor was any testing done. So we're trying to figure out if there's a way through the virtual programs now to do pregnancy testing and or screening for syphilis and HIV. We also heard overwhelmingly from pregnant women that they were really afraid that their babies would be taken away from them, and that was unfortunately a reality. So in Edmonton, when I first started, I used to be the medical director of the Edmonton STI clinic. And in the mid 2000s, I would go out with our outreach team of nurses and community health representatives. And I learned that there were 100 pregnant women delivering in Edmonton every year who were not accessing prenatal care before delivery. And this is what the women were saying. And it was a reality. And at that time, we had no housing programs that would support women who were using substances that had a harm reduction model. The only facilities that were available were abstinence-based, so they had to commit to stop using completely, which of course is not a reality for all women. And so we did some additional work together with other community groups, and we now have the first program in Alberta that will has been very successful in supporting women who are using substances and with more of a harm reduction model. Of course, that program already has a long waiting list and needs to be expanded, but it is at least a start. Um, so just to go back to HIV for a minute, I mentioned to you that having a genital ulcer disease such as syphilis can increase the risk of transmission of HIV, which is why I personally feel very, very strongly that anyone diagnosed with syphilis should also have not only baseline HIV testing, but serial HIV testing. And with the discussion with our partners here, which is why when we first started using point of care tests here in Alberta, we decided to use a combination test with syphilis and HIV point of care in the same test. What about syphilis and HIV in co-infected persons? So the presentations of syphilis may be more severe or atypical, but honestly, most of the time it looks exactly the same. But I have seen more severe manifestations, particularly in persons with low CD4 counts, certainly below 200, and if they're below 50, the manifestations can be really quite severe. And as I mentioned to you, it may cause a problem with the diagnostic test. So it's good to bear that in mind. that in somebody with low CD4 counts, you might need to do additional testing to figure out whether they have syphilis or not. They're also much more likely to develop neurological involvement, particularly again with CD4 counts below 350. There's about a 3 times increase. HIV itself can cause what's called pleocytosis, so that's elevated cell counts in the cerebrospinal fluid. So it can make it difficult to figure out whether or not they do truly have neurosyphilis or not. And so we have to interpret that a little differently. And sometimes in the past, we used to recommend that routine spinal taps or lumbar punctures were done with low CD4 counts or where the syphilis test was high, and particularly if they were not on antiretroviral therapy. But over time, I have personally moved away from doing routine lumbar punctures, and we'll do that now really only if they have neurological symptoms or if after treatment their syphilis tests have not responded properly. The good news is that even if they are living with HIV, the treatment is the same, even if they have neurologic syphilis. And treatment failures are extremely uncommon, even in those who are not on antiretroviral therapy. But it is, of course, something that we do need to make sure that we follow those individuals a lot more closely.